Welcome to our summit. This is a very hot week. This is our third year. We booked this time ages ago, honest. We didn't realise it was the hottest week in healthcare.
We're not carrying on as we are changing, and we are changing. It's not about the bill alone. It is about a process of modernisation, of reform, of empowerment across the service.
But there has to be clarity about why there's a need for change. Partly it's economic, as we know, but partly it's value quality driven. If people experience change as the withdrawal of service, of course they're not in favour of it.
For my whole career in improvement, probably the climactic issue has been scale. How do you take the great things that we know that can be done in healthcare and bring them to large scale?
When I was a young medical doctor, our policymakers told us that healthcare is expensive, but one day India will become a rich country and everyone can afford healthcare. We looked at the richest countries in the world which is struggling to offer healthcare to the citizens. We have to change the model of delivering healthcare.
I mean, you know, what's typically happened in New Zealand is that you have a funder who's slightly suspicious of general practice.
Same here.
You know,
yeah.
It's a bit of an international disease, I think. It's really difficult for a funder or a hospital to try and interact with hundreds of small providers. But if you've got some infrastructure that's got some consistency, it obviously makes the conversation more doable.
One of my concerns about health innovation is we test things as discrete units. But my guess is that when you're looking at changing whole systems, in fact, most of the gains will come from assemblages of a number of different elements, which will then reinforce each other.
I think the opportunity that we've had at Mount Sinai and UHN has been really about taking a lot of those innovations by putting them together in terms of creating an integrated system across the care continuum that really is focused on delivering better patient and system outcomes.
Certainly when you're designing pathways of care and seeing the whole pathway through the patient's eye, it is frightening to see what the patient goes through as far as the care is concerned.
We really ought to think in terms of should we actually be combining at the local level social care and health by actually having a single administrative system.
If we're going to deliver the kind of integrated services we talk about, that means, in plain English, transferring significant amounts of resource out of the acute sector in order to be able to develop community services.
Across the NHS, there are many, many pockets of excellence in which true integration has happened. And that is when they've completely discarded all the financial element of this. Groups of leaders have come together and have achieved beyond any belief, actually. They've dealt with all the challenges.
So risk, as it's been mentioned, it's part of this debate about centralisation, about localisation. It's about issues of autonomy and control. A risk-averse system might be a very centralised one, but maybe it hasn't got that local discretion, that local innovation, that local energy. Particularly important at the moment as we think about CCGs, potentially smaller commissioning entities, and I'll give some examples of why that's important. More complex markets, a more complex range of actors involved in the health economy, and a renewed emphasis on organisational autonomy. I think the issues for me are there about how we design risk systems that reinforce the right incentives for efficient care, and we don't rely on a process of just bailing out failures for when people are perhaps inefficient or overspending.
There will have to be a shift in resources between the NHS and social care, with changes in the way care and support is delivered.
2% a year real after this spending review looks like the sort of upper bounds of anything that might be possible. Health service needs to transform its productivity not for 4 years but for a decade.
Productivity gains of the kinds that are needed are accessible. That we can do it. We can probably double what we need. I mean, I think it's healthcare is really broken now, and it could be fixed well.
Nothing more complex than the effective sharing of data, transparency. Knowledge could be possibly the fastest, most effective thing we have to deal with this challenge of efficiency, not just in healthcare, but in public services in general.
You know, we've probably got enough money, it's just being spent really badly.
That's right.
So you've got, amongst really significant organisations, a groundswell of not saying everything's great, but of actually saying we need these changes. Now, if we all can't turn that into something for a year before the next election, we should give up.
The healthcare providers who will succeed in the new NHS will be the ones who integrate the most successfully, who innovate the most creatively, who push the boundaries of what is possible and never stop pushing.